Okay. And now we're going to start the next symposium sponsored by Sandoz. And the topic will be updates in the management of the luminal breast cancer. And our speaker will be Professor Dr. Muhammad Sabri. Dr. Muhammad.
Thank you for dear colleagues. Thank you for the chairperson. I want to highlight about fulvestrant in breast cancer. And thanks you for Sandoz company for sharing with me these updates about fulvestrant use in breast cancer. I will start with historical timeline of therapy of breast cancer, started from chemotherapy and shifted to endocrine treatment for the patient with luminal A and B. We started with oophorectomy, then passing through tamoxifen, then anastrozole, then started of fulvestrant at 2002 as a single agent versus anastrozole. Then we come to the era of CD46 inhibitors, and now we are in the era of alpelisib and PIK3 mutations inhibitors, and the first predictive biomarker for treatment of breast cancer patients. If I go more deep, the combination started 10 years ago by combination of everolimus plus mTOR inhibitors, then followed by palbociclib in 2015, and followed by ribociclib and abemaciclib in 2017 and 2018. And lastly, we have alpelisib approved plus fulvestrant according to SOLAR trial and BELIEF trial as a combination for a patient with PIK3 mutations. So the started of fulvestrant between around 20 years ago. They started fulvestrant by a confirmed trial. There is confirmation that a higher dose of fulvestrant is superior than the half dose of 250 milligrams every 4 weeks. And after 6 years, we have updates for Falcon trial have highlighted in the 2016. That's comparing fulvestrant versus anastrozole as a primary endpoint was PFS, and they found that a patient with a bone-only disease has much more better overall survival and PFS comparing with patients with visceral disease. And also, we started the era after 2 years after releasing of first Palomas trial in 2015 till 2018 by Palomas and Monarch and the Mona Lisa trials. We found that fulvestrant was combined with CD46 inhibitor as in second-line treatment in the Mona Lisa 3 patients and the Paloma 3 patients. We have 3 main trials testing fulvestrant plus CD46. We have Mona Lisa 3 trials, Paloma 3 trials, Monarch 2 trials for a primary resistant endocrine patients with cystic breast cancer. So in this slide, I can abbreviate the milestones of using of fulvestrant in the, our daily practice. We have the only trial including fulvestrant plus ribociclib in the first line is the Mona Lisa 3 trial. And in the same trial, including the patient in the second line to receive ribociclib plus fulvestrant in second line, and also have palbociclib plus fulvestrant as a second line treatment, and abemaciclib in Monarch 2 trial, which is indicated for the primary resistant patients to give abemaciclib plus fulvestrant as a second line treatment. So in the NCCN guidelines, they fulvestrant as highlighted as category 1 treatment option, either single agent or in addition to the CD4/6 inhibitors. And according to the phase 3 Paloma trials, we found that there is a benefit of adding of palbociclib plus fulvestrant as second line treatment after failure of an AI. Shortly, I will highlight the PFS of the Paloma trial. They have a PFS of 54% of response rate achievement in the intended to treat population for the Paloma 3 trials. And here is the analysis of time deterioration to pain score is much improving with fulvestrant plus palbociclib as a second line. And also we have these clinical criteria that predict that the Paloma 3 will go for better overall survival and progression-free survival. The patient with prior endocrine sensitive, non-visceral disease, ECOG prognosis of 0 or 1, no prior chemotherapy for advanced breast cancer setting is a very good factors and very prognostic factor to have a very good response of combination fulvestrant plus palbociclib. So there is absolute overall survival gain, 6.9 months between palbociclib fulvestrant versus fulvestrant alone. And this is MONALEESA 3 trials, which is the most heterogeneous trial, including 2 cohorts of patients receiving ribociclib plus fulvestrant as a first line for hormone-sensitive patients, and patients receiving ribociclib plus fulvestrant for a patient with secondary resistant patients. So we can see that patients receiving ribociclib plus fulvestrant achieving better PFS in the second line treatment. It is about 7 months improvement in the PFS comparing fulvestrant alone, and also the patient with early relapsing, which is a worst subgroup of patients in this study, they also achieving a good PFS prolongation of combining ribociclib plus fulvestrant versus fulvestrant alone. We have here that some also time to first chemotherapy is prolonged in the patient receiving ribociclib plus fulvestrant is a second line. We have here near 20 months delay to first subsequent chemotherapy in the patient receiving ribociclib plus fulvestrant in the second line. So we can see here that also there is a lot of overall survival benefits updates in the MONALEESA 3 trials concerning that 46% of patients receiving ribociclib plus fulvestrant are still alive after 5 years of follow-up. This data published in the last year, and we have now data of San Antonio and ESMO updates and ASCO updates after 6 years of giving fulvestrant plus ribociclib, that the patient have extended benefit of overall survival and PFS after 6 years of follow-up from the initiation of treatment. So this the early relapser for the in the MONALEESA trials receiving fulvestrant plus ribociclib, either early or secondary relapser, they again benefit from combination, but the second relapser or late relapser are gaining more benefit concerning PFS, but this study didn't include the primary resistant patients like Monarch 2 trials. So in the first line, we have also the data from MONALEESA 3 trials for the patient de novo patients. If we can explore the MONALEESA trials to get more deep, we have two cohorts of patients receiving ribociclib plus fulvestrant as a first-line treatment, and they considered as the sensitive patients, other de novo patients, or patient relapsed after 1 year of finishing of 5 years of adjuvant treatment, or the patient receiving second line treatment, either early relapser before 1 year of finishing of their adjuvant, or after 1 year, or within the chemotherapy regimen within the 1 year of first year after 5 years of new adjuvant treatment, or patient progressed on AI as a first-line treatment. By specifying to go more deeper, you can imagine that patient with treatment naive or TAM naive represents about 49% of patients in this study. That's why in the first line, they have achievement unbelievable PFS with combining fulvestrant plus ribociclib. We have a median PFS of 33 months, 0.6 months versus 16.5. And this is the most significant and most magnificent improvement in the PFS of all studies comparing CD46 plus fulvestrant as a second-line treatment. And these results are specifying for the patient who are receiving fulvestrant plus ribociclib as a first-line treatment, either de novo patients or patients with hormone-sensitive category. So we have also the overall survival benefit of the patient receiving fulvestrant plus ribociclib in the first-line treatment. We have here that after 5 years, the two curves still separated from each other, still maintaining response of combining ribociclib plus fulvestrant as a first line. So in the last ASCO base this year, they highlighted that after 6 years of follow-up, they also have overall benefit of combining fulvestrant plus ribociclib, either first line or second line, after extended follow-up of 6 years. They have demonstrated 6 months longer median also benefit in the last year after 5 year follow-up of combining fulvestrant plus ribociclib as a second-line treatment or early relapse definition. So for the chemotherapy-free, for the second line, there is 10 months longer with ribociclib plus fulvestrant versus placebo plus fulvestrant in time to initiate chemotherapy. So in the primary resistance, we can find that it is a unique trial, Monarch 2 trials, they including the patient uniquely primary resistant to receive fulvestrant plus abemaciclib as a second-line treatment. And this is, I think, the only study including the primary resistant patients to be enrolled in this study, and also they including premenopausal patients in the study to receiving fulvestrant plus abemaciclib in the both postmenopausal and premenopausal patients. And also the achieving in T3 population, the achieving improvement in PFS about 7 months between fulvestrant only versus abemaciclib plus fulvestrant. And in the Monarch 2 trials, the design is to receive abemaciclib, as I said before, plus fulvestrant versus fulvestrant alone, and the assessed PFS can we see in this slide that there is significant improvement in the PFS in the all population receiving abema plus fulvestrant. Also in the this slide, we can see that median overall survival benefit is 9 months, 0.4 in favor of combination of fulvestrant plus abemaciclib. Also, the overall survival benefit in this trial is comparing the primary resistant patient with secondary acquired resistant patients, and this is a very strange results, not be explained by any biomarker. They should go for retrospective analysis to go for this explanation of this. That's why a primary resistant patient have a good PFS with abema plus fulvestrant versus patient with secondary acquired resistance. This is a very optimistic and very good take point for abema in comparing with balbo and ribociclib to be given in the primary resistant patients and to have a good resistance comparing with secondary resistant patients. So what's next step? All the guidelines now is recommending that some PIK3 mutations should be performed to help guide to treatment paradigm in our scenario. And we have here in this slide, we have a multiple downstream pathway. I think PIK3 mutations represent 40% of patients' population having this mutation burden, and this is attract us to go more deeper to study the patients in the umbrella of PIK3 mutations, and we can change our treatment paradigm according to the PIK3 mutations. Specifically after approval of alpelisib as the first anti-PIK3 mutation blocker, alpha blocker, to be highly specific to block the PIK3 mutation for those patients. So fulvestrant plus alpelisib for PIK3 mutated patients, the first line is keeping with SOLAR trial. They published in 2015. There is no patients at that time receiving CD46 because it is the starting of the pallomas. So in SOLAR trial, you can find that we have just 20 patients only receiving CD46 and progressed and receiving alpelisib plus fulvestrant after failure on CD46. Most of patients progressed on AI and receiving fulvestrant plus alpelisib as a first line metastatic disease. In the second line, the BELIEF trial designed to study the effect of alpelisib plus fulvestrant in the progressor on the CD46 after first line CD46, the patient receiving alpelisib plus fulvestrant as a second line treatment. That's why we have 40% of patients with PIK3 mutations, and these patients have a shorter PFS and shorter overall survival. They have aggressive disease, more tendency to have visceral metastasis, early relapse on CD46, plus hormonal treatment. Even with chemotherapy, there are poor responder to chemotherapy. So the alpelisib is the first drug given on the predictive biomarker PIK3 mutation to be given with fulvestrant in the family of hormonal treatment, either upfrontly or post CD46 progression. So this is the SOLAR trial. They randomized phase C trials, randomized patients to receive fulvestrant plus alpelisib in the arm of PIK3 mutated patients. So they have no more patients progressed on CD46 because the date of publication with at 2015, there is no many patients receiving CD46. They including only 20 patients progressed on CD46. That's why the BELIEF trial designed to answer the question, what's the position of fulvestrant plus alpelisib post progression of CD46 plus AI. So in this trial that we have now, that's a SOLAR trial, that's PIK3 mutated occur in approximately 40% of the patients. We have here PFS of 11 months improvement in the PFS in the favor of alpelisib plus fulvestrant as a first line treatment. And it is a conclusion, significant prolongation of PFS and greater overall survival benefit for patients with receiving alpelisib plus fulvestrant than placebo plus fulvestrant among patients with PIK3 mutation patients in the SOLAR trial. And this is the guidelines that PIK3 mutations should be done either on tissue, on liquid biopsy in the first progression on the or the first presentation of metastatic disease. So this is the recommendation of NC guidelines that alpelisib was included in the treatment options plus fulvestrant in the patient with PIK3 mutations. In the later version of NCCN guideline, they have a PIK3 mutated patients in second line to be given with fulvestrant as second line treatment. Before deciding option of treatment session, do you think that the fulvestrant position will change it after PIK3 mutation area? I think 60% of patients doesn't have PIK3 mutations, and we can give fulvestrant as early as MONALEESA trial to be a first line and to enjoy the response rate and PFS and overall survival benefit of giving fulvestrant early plus ribociclib for those patients with non-mutated PIK3 mutations. And this is a challenge now, is to put the fulvestrant in its position. If it is PIK3 mutations, it's better to postpone it to give it with alpelisib or to start alpelisib plus fulvestrant as easy as possible as SOLAR trial. If non-mutated, you can give fulvestrant as early as MONALEESA trials, giving ribociclib plus fulvestrant as a first-line treatment. So here is the, again, MONALEESA trials, the only trial including ribociclib plus fulvestrant is the first-line treatment. And again, this is the design of the trial. And this is the cohort of patients receiving fulvestrant plus ribociclib in the first line. And again, there is a consistent response to the combination of fulvestrant plus ribociclib in the first line treatment for the patients. So by this highest PFS in those patients receiving fulvestrant, I think it's wise to define who is a patient harboring PIK3 mutations or not, to render fulvestrant as early or to keep it late, to use it with alpelisib in the second line, or use it fulvestrant as early but with alpelisib as the first line for the patient with PIK3 mutations. So this is also the overall survival benefit of the patients receiving fulvestrant as a first-line treatment. It's patients, the only trial showing combining fulvestrant plus ribociclib, showing overall survival benefit in the highly hormone-sensitive population in the patients receiving ribociclib plus fulvestrant as a first-line treatment. You can see here that again we have 33.6 PFS compared to 19.2 for fulvestrant alone, in favoring patients receiving ribociclib plus fulvestrant as a first line. So there is last ASCO updates about MONALEESA trials. They have also improvement in the overall survival patient who is harboring visceral metastasis, especially with the liver mets. So we have here that patient who is harboring visceral mets, there's 38% relative reduction of deaths in the patient receiving fulvestrant plus ribociclib. This is not achieved in the PALOMA-3 trials, by the way. They have only demonstrated benefit for the patient with bone only, the vessel disease achieving much more less results by combining fulvestrant plus palbociclib. In this study, ribociclib achieving more better than palbociclib when combining with fulvestrant, especially for the patient with liver metastasis. So overall survival benefit remain the gold standard for demonstration clinical benefit and improvement in overall survival in direct clinical benefit to the patients. We have here the milestone of fulvestrant. We started from tamoxifen, then AI, then fulvestrant for a patient with sensitive patient population with bone-only disease. We have 19 months improvement in the overall survival, followed by the era of fulvestrant plus CD46 as the first line or second line, and ended by fulvestrant plus alpelisib as first line for the patient with PIK3 mutation positive. So my conclusion here, the combination of ribociclib with fulvestrant provide longest PFS benefit in 33 months in the first line late relapsed patients based on monalization trial results. And second line, early relapser, primary resistant patients, we can find the Monarch 2 study that studied abemaciclib plus fulvestrant as a second line treatment exclusively for the patients harboring primary resistant patients. In a very near future, testing PIK3 mutations, and we are now in this future, will play a role in identifying patients with benefit from PIK3 inhibitors as first line SOLAR trial or brief trial as second line after CD46 progression. Also, fulvestrant alone proved PFS of up to 22 months in patients with non-vessel disease when combining with fulvestrant, and CD46 inhibitor combination is standard now of care for the patients with advanced breast cancer with hormone-positive patients whenever possible. But maybe the PIK3 mutations is changing this sentence in that time of highlighting of SOLAR trial or and approving of the PIK3 testing. Maybe this upfrontly CD46 may be changed to be instead to give fulvestrant plus palbociclib as a first line instead of CD46 for the patient with PIK3 mutations. Thank you.
Thank you, Dr. Sabri, for this nice presentation about the role of fulvestrant in the treatment of metastatic hormone receptor positive breast cancer. And now, because we are so late, we may have one or two questions. Okay, let me ask you something from our practice every day. Many times we find patients that CDK is not affordable. And now you have a patient presented metastatic, primarily for the first time she is metastatic, and of course she cannot pay for CDK, for example. Would you like to start with AI single agent or fulvestrant single agent? Dr. Ehab Mustafa was asking this question just outside.
Yes.
If CDK are not affordable, and you have either AI single agent or fulvestrant single agent, would you like to start with fulvestrant or AI?
It depends on the site of meds, because if it is bone-only disease, you can obey that's a Falcon trial comparing fulvestrant plus anastrozole versus anastrozole. They have superiority of fulvestrant for the patient with bone-only disease. But in the patient with vessel disease, there's no difference. You can start with fulvestrant or AI. By my opinion, after era of PIK3 mutations, don't give fulvestrant as early before knowing PIK3 mutations, because we are in an upcoming era of giving CD46 in the non-mutated patients, or changing CD46 as a rule now to give palbociclib plus fulvestrant. So my advice, if you have non-bone and you have vessel disease, you should go for AI firstly if cannot afford for CD46.
Bone-only disease.
Yes, bone-only disease.
Yes.
And also patient with stem-naive, the most important subgroup population in Falcon trial achieving benefit from fulvestrant versus anastrozole.
Okay. Any other questions or comments? Okay. Thank you, Dr. Muhammad,
Thank you.
and thank all of you. And then coming for the next symposium.